Hello, and welcome to the second video on adrenal pathology. Here we're going to focus on adrenal cortical insufficiency. We'll look at primary and secondary Addison disease, and then the assessment, treatment, and then overall prognosis. So when we talk of adrenal cortical insufficiency, again, we can talk about primary, secondary, tertiary, or functional adrenal cortical insufficiency. Primary is Addison disease, and this is results from destruction of the adrenal gland itself with low cortisol, DHEA, and typically low aldosterone. So all of the adrenal steroids are suppressed. The good thing is this is pretty rare, 35 to 140 per million of the population. There's a higher female to male ratio because this is primarily caused by an autoimmune disease, and that's characteristic that autoimmunity is more common in female patients. Usually diagnosed in the third to fifth decade of life. And the good thing here is you actually need to lose over 90% of both adrenal cortices to have any clinical manifestations. The bad thing is once you have clinical manifestations, you've lost over 90% of your adrenal cortices. The most common presentation is for this to come on gradually, but it can occur acutely. And the risk there is an acute adrenal crisis. So if you jump down here to acute crisis, that's going to be a dramatically suppressed cortisol and aldosterone, and that's going to need immediate cortisol and usually aldosterone replacement, and again that's through fludrocortisone, which has a longer half-life. Aldosterone half-life is about 20 minutes, so that's not very well taken as a supplement. In fact, I think there's only one pharmacy in the country that actually prescribes a compounded aldosterone and bioidentical aldosterone. But again, because of its short half-life, it's not very practical to use for these purposes. So this can be fatal if this is not corrected. Actually, with Addison's itself, it's almost always fatal eventually without proper cortisol replacement. But with the replacement of both glucocorticoids and mineralocorticoids, the prognosis is usually excellent. Secondary adrenal cortical insufficiency, again, is decreased ACTH, and this will have usually normal aldosterone with the low cortisol. What happens is with the chronic loss of ACTH, the zona fasciculata and the zona reticularis atrophy. And so then the cortisol and DHEA secretion further decreases. Generally, though, the symptoms are more mild, and adrenal crisis with secondary adrenal cortical insufficiency is pretty rare. And then tertiary would be loss of CRH, and again, one of the most common causes of that would be abrupt withdrawal of an exogenous glucocorticoid. So if a person's on 60, 70, 80 milligrams of prednisone, and they've been on it for weeks and they suddenly just stop cold turkey, that can initiate a tertiary adrenal insufficiency. And that typically is going to manifest like a secondary, although it is possible to have an adrenal crisis with that. So that's why we're always very concerned about being sure that we taper any glucocorticoids and don't do abrupt withdrawals. And then functional, again, would be what many people call adrenal fatigue in the functional medicine world, but this is really more appropriately named HPA axis dysregulation or pseudo-Addison's. And this is where we have a 24-hour fluctuation of cortisol, but the rhythm is disturbed. And we usually have a low cortisol awakening response. Not recognized, at least yet, in the biomedical circles, and that's probably because this doesn't really require replacement therapy with hydrocortisone, unlike Addison's. And so there's not a whole lot that can be done from the conventional angle, but this is something we can definitely, from a naturopathic angle, offer a lot to help support a patient with. There's 4 types of stressors that can disrupt the HPA axis. So psychological, feeling of loss of control or overwhelm, a disruption of the circadian rhythm, and that can be from night shift working or in unhealthy sleep rhythms, etc. Glycemic dysregulation like insulin resistance and hyperglycemia, and then chronic inflammation, especially with increased IL-1. All of those are notorious for disrupting the HPA axis, potentially initiating this functional HPA axis dysregulation. It's best assessed not with plasma testing of cortisol, but with salivary testing, usually over 4 time points during the day. This is not provoked with any sort of stress or anything. We just get baseline cortisol. And usually we get the first salivary test 30 minutes after waking, and that will tell us our cortisol awakening response. If we have a decreased, again, CAR, this is more Addison-like, and that's been associated with atypical depression, PTSD, chronic fatigue, and seasonal affective disorder, versus an increased cortisol awakening response that's more Cushing's-like, and that's going to be found more with typical depression and anxiety. So lots of research literature on how depression, anxiety are related to HPA axis dysregulation. Okay, so that's an overall summary of the adrenal cortical insufficiency disorders. Going a little deeper into causes of primary adrenal cortical insufficiency. Again, this is from destruction of the adrenal gland, so we're going to get a loss of all the adrenal steroids. Autoimmune disease is the most common. About 80% of cases, the adrenals become small, atrophic, they develop a thick capsule, and they become infiltrated with lymphocytes with fibrosis. And this is exactly what happens in the thyroid with Hashimoto's. So it's very similar. In fact, there is a crossover. People who are at higher risk of Hashimoto's are going to be at higher risk of Addison's, although again, Addison's is very, very rare. So we rarely see true Addison's in the clinic. The medulla is preserved, so we continue to secrete catecholamines effectively. We think the actual autoimmune damage is from antibodies against 21-hydroxylase. And so that knocks out your steroid production. It can be isolated adrenal destruction, or it can be found in the context of what's called autoimmune polyglandular syndrome, type 1 or type 2. So APS1 or APS2. And these are autoimmune diseases causing multiple endocrinopathies. Had a patient with APS2 who had Hashimoto's. She had actual autoimmune destruction of her pituitary. She also had type 1 diabetes from autoimmune destruction of the beta cells, and Addison's disease, and premature ovarian failure. So from autoimmune destruction of the ovaries. So she was on replacement therapy for every one of those different hormones. Quite a regimen. So that's the most common cause of Addison's. Infections, we see these less commonly now, but TB used to be a very common cause prior to 1920 of Addison's. The tuberculosis bacillus would infect the adrenals and cause them to infarct. Fungi and immunocompromised states in HIV/AIDS can cause Addison's. And then disseminated meningococcemia. So this would be from the Neisseria meningitidis, bacterial cause of bacterial meningitis. And this can cause adrenal hemorrhage. I'll talk about that here in a minute. Metastases of tumors from the lung, GI, breast, or renal cell carcinomas. Also lymphomas, both non-Hodgkin's and Hodgkin's. And all of these can cause primary adrenal cortical insufficiency. You're going to need bilateral involvement of both adrenals, and again, over 90% of the adrenals have to be destroyed before we start seeing symptoms. Adrenal hemorrhage, this is known as Waterhouse-Friderichsen syndrome. It's kind of a board question, that name. What is Waterhouse-Friderichsen syndrome? It is an adrenal hemorrhage causing adrenal collapse, usually related to Neisseria meningitidis septicemia. Or disseminated intravascular coagulation or endotoxic shock. So that's Waterhouse-Friderichsen. Something, again, you're probably going to see more in urgent care or emergency room settings, not so much in primary practice. Different drugs can inhibit the adrenal. So I've mentioned before, ketoconazole, an antifungal, inhibits adrenal steroid synthesis. So does meteropone. Mitotane inhibits steroidogenic enzymes, but also destroys the adrenal tissue itself, and so forth. So these are not commonly, especially in the dosages that you would need to have an inhibitory effect on the adrenals. These are not commonly prescribed. They are going to be prescribed, though, for patients with Cushing's from, for example, an adrenal tumor, adrenal adenoma hypersecreting cortisol. These would be potential medications to use in those cases. Other causes would be amyloidosis, hemochromatosis, again, congenital adrenal hyperplasia or adrenal dysgenesis congenitally, and then adrenal leukodystrophy, which is an X-linked disease. It's a disorder of the paroxysmal fatty acid beta oxidation, so we don't break down fatty acids adequately. So fatty acids accumulate, they damage myelin, can result in the nervous system in seizures, but it can also result in adrenal insufficiency and failure in males of the testes. So not common, but that is in the list of causes of primary adrenal cortical insufficiency. Secondary, again, with low cortisol and DHEA, normal aldosterone. The most common cause here would be, again, pituitary pathology. Now, exogenous glucocorticoid therapy, depending on the text you see, is either pinned to tertiary or secondary. Again, they're kind of interchangeable. But basically, going cold turkey off glucocorticoid therapy will cause secondary or tertiary glucocorticoid insufficiency. And then hypothalamic tumors and HPA axis dysregulation could cause tertiary. And then finally, with our adrenal crisis, this can happen from sudden withdrawal of the corticosteroid therapy or sudden destruction, again, causing a hemorrhage in the adrenals from an infection, causing Waterhouse-Friderichsen syndrome, or a sudden worsening of Addison's disease. All of these could cause an adrenal crisis. Okay, so that's more the full list of causes of all the different types of adrenal cortical insufficiency. So what are the general clinical presentations of adrenal cortical insufficiency? Again, it's going to vary depending on if it's primary, secondary, or tertiary. But generally, all of them will show some signs of weakness, fatigue, anorexia, weight loss, and even fever, low-grade fever. So if you see a low-grade fever in a patient with severe hypotension, weight loss, weakness, and so forth, you might want to suspect Addison's disease. So these general symptoms are present in nearly all cases of Addison's, but less so in the other secondary and tertiary causes. Secondary, going to have less severe symptoms. Fever is going to be uncommon in the secondary causes. Hyperpigmentation is going to be common in primary Addison's with increased MSH, and especially in sun-exposed areas, in pressure areas like the knuckles, toes, elbows, and knees. Increased black or brown freckles, increased pigmentation in palmar creases, nail beds, nipples, areolae, perivaginal, perianal mucosa. In patients with darker skin, that's maybe where it's going to show up primarily, is like in the creases in the palms. In the later stages, you might even see hyperpigmentation of the oral mucosa. And then vitiligo in some cases of Addison's because of a concurrent autoimmune condition going on there. So those would all be potential manifestation of primary. This is going to be a lot less common, no hyperpigmentation in the secondary adrenal cortical insufficiency. Hypotension, common in Addison's, over 90% of cases. Pretty severe salt craving in about 20% of patients. It's going to be less common in secondary and also tertiary adrenal cortical insufficiency, and that's because aldosterone is usually intact. Hypoglycemia can be severe in primary, more common especially in children, not as common and more mild in secondary. GI, nausea, vomiting, diarrhea, very common in primary, more mild in the secondary. And then amenorrhea is going to be very common in women due to weight loss or primary ovarian failure due to the autoimmune disease destroying the ovaries. And then might have decreased also adrenal androgens, decreased DHEA, so loss of axillary and pubic hair in females will be more noticeable. And these will all be uncommon in the secondary adrenal cortical insufficiency. And then adrenal crisis, we've talked about this several times now, and this is going to happen more in patients with Addison's, for example, who are exposed to infection, trauma, surgery, severe dehydration. They go traveling, there might be increased stress, and that results in severe hypotension with even hypovolemic shock, fever, dehydration, volume depletion, nausea, vomiting, anorexia, weakness, lethargy, confusion, depressed mentation, hypoglycemia, and so forth. So this can be fatal if not corrected. Usually it is fatal unless corrected, but today with better medical interventions, this has a very good prognosis. This is all going to be uncommon in secondary or tertiary adrenal cortical insufficiency, but still possible, and especially after abrupt withdrawal of corticosteroids. All right, so that is kind of an overview of the clinical presentations you might see related to these. Okay, so what's the workup for adrenal cortical insufficiency if you suspect this in a patient? Well, we're going to look at our clinical findings, of course, everything we just went over in the last slide, and our labs and different imaging. And then there's a special test called the ACTH stimulation test that we might need to confirm adrenal reserve. So CBC in the primary adrenal cortical insufficiency is going to show usually anemia. And that's going to be primarily because of the loss of DHEA as an androgen. DHEA can help stimulate the bone marrow to make more red cells. That's a pretty common actually cause of anemia. I've seen that a lot in females where we find anemia can be normocytic but often microcytic, and they maybe have low ferritin as well, and they're taking iron, and that's not correcting the problem until we correct the DHEA, and then suddenly the iron and the ferritin levels go up. Relative lymphocytosis in the primary adrenal cortical insufficiency. Secondary, we're going to see more normal chromic normocytic anemia if it's going to be present, more neutropenia, lymphocytosis, and eosinophilia. CMP for the primary adrenal cortical insufficiency, low sodium, high potassium. The anion gap will be increased, leading to metabolic acidosis, and that's basically due to decreased aldosterone causing decreased renal acid secretion, so acids are building up in the blood, and decreased glucose, very characteristic. Going to be a lot more mild with the secondary, maybe decreased sodium. Usually potassium, creatinine, bicarbonate, and BUN are normal, and the plasma glucose may be low, but usually not particularly low. Might not be under 60 milligrams per deciliter, which is the cutoff point for hypoglycemia in a non-diabetic adult. The serum ACTH you need to gather at 8 a.m. in the morning, and usually the ACTH will be over 4,000 picograms per milliliter, and that's because the pituitary is trying to turn on the adrenals, and they might have also low increased renin and potassium and low aldosterone if those are measured. In the secondary adrenal cortical insufficiency, there'll be low ACTH. So ACTH will be the third major test to do here. And then we check cortisol, and we can do that in several ways. The most common one is to do a total serum cortisol, which is a measure of the free and the bound cortisol at 8 a.m. This is the standard test. And the levels of cortisol between 10 and 20 micrograms per deciliter are considered normal. If it's under 3, that strongly suggests insufficiency. Now again, the total is going to depend on the CBG and albumin levels, and that can be affected by liver, kidney disease, oral estrogens. So you might need to get a free cortisol if you're concerned about those. This test alone is more like a screening test. It's not enough to confirm adrenal cortical insufficiency. That's going to have to come with the ACTH stimulation test. So that's one way of assessing. The other is salivary at 8 a.m. Potentially more accurate, not as commonly used. It's not yet a validated assessment tool, and less than 1.8 nanograms per deciliter would suggest insufficiency. Again, we need to follow that up with other tests. Urine testing is not accurate for assessing adrenal cortical insufficiency. It will be important for excess, though, like in Cushing's. All right, so that's cortisol is our next test, and then ACTH stimulation test. Usually if I suspect a person has actual adrenal cortical insufficiency, I'm going to probably refer them out at this point. You know, if you wanted to do the next test in line, that would be the ACTH stimulation test. It's also called the co-syntropin stimulation test. Co-syntropin is the name for synthetic ACTH. So basically, this can be done as what we call a high-dose test or a low-dose test. The high-dose test is the one that's most commonly prescribed. We give 250 micrograms of the co-syntropin intramuscularly or IV. and then you get a cortisol at baseline, 30 minutes and 60 minutes after that. And you should see a peak cortisol secretion in 30 to 60 minutes above 18 to 20 micrograms per deciliter. In the primary adrenal insufficiency, you're not going to see that cortisol rise. So that would be one way then of confirming that diagnosis. Could be normal though in patients with partial secondary adrenal insufficiency. So that's where sometimes we do a low dose test to test for that, but that's not as commonly measured as the high dose test. Okay, one final test would be called the Meteropone test, and that's used to diagnose, again, the insufficiency with pituitary reserve. And here, if we suspect a pituitary ACTH deficiency, the Meteropone blocks cortisol synthesis. It inhibits 11-beta-HSD1. So basically, you are going to, by giving Meteropone, it's going to cut off the cortisol secretion, and so we should see the pituitary increasing ACTH in response. If it doesn't, then we can kind of confirm secondary or tertiary insufficiency. All right, so those are our two specialized tests for adrenal cortical insufficiency, but that should give you an idea of how to approach the workup of patients if you suspect this. Okay, finally, treatment of adrenal cortical insufficiency. The first is to really determine if the patient is in or at risk for an acute adrenal crisis, or if this is more chronic. If they're in an adrenal crisis, this is an immediate referral to the ED, and they're going to need to be stabilized on hydrocortisone, usually intravenously with fludrocortisone. Typically, though, this is going to happen more chronically, but patients will usually, especially in primary adrenal cortical insufficiency, are going to need level 3 therapies, the replacement therapy. For Addison's, specifically level 1 and level 2, in other words, herbal, lifestyle modification, etc., is not enough to treat Addison's. This needs replacement therapy, just like type 1 diabetes or advanced Hashimoto's. The typical replacements are going to be of the cortisol, and that's through hydrocortisone and fludrocortisone, which replaces aldosterone. There's no guidelines for replacing DHEA yet, but many physicians will also add that in as well. Referral is going to be usually needed here for the ED, for adrenal crisis, and then to an endocrinologist if necessary. And we should be on the lookout here again for adrenal crisis, which would be, again, severe hypotension, hypovolemic shock, fever, severe dehydration or signs of volume depletion, nausea, vomiting, anorexia, weakness, lethargy, confusion, depressed mentation, and severe hypoglycemia. So let me go through the different levels on the therapeutic order. Let's start with replacement therapy first. So that is, usually we're going to do this in conjunction with an endocrinologist. I think this is outside the realms of most primary care providers to really manage effectively. So I would recommend a referral to endocrinology. And that's going to be usually chronically with replacing hydrocortisone. Again, that's the same thing as cortisol. 10 to 15 milligrams in the morning, and then 5 to 10 milligrams in the between 4 and 5 p.m. And that's going to need to be increased if we know there's going to be increased stress, if the patient gets sick, if they're traveling, things like that. We may need to double the dose. Fludrocortisone would be the mineralocorticoid replacement, and that's 0.05 to 0.1 milligrams in the morning. And then potentially DHEA anywhere between 10 and 100 milligrams a day. I'd start low and titrate up. We're going to monitor the symptoms, like the weakness and the fatigue, and then their weight, blood pressure, and electrolytes. We're going to check their circadian rhythm, and then going to look at and do that through the plasma, but more commonly through the salivary cortisol. I would typically kind of approach it that way. Patient education about the condition, and then giving them a medical ID tag would be important, so that if they end up having a syncopal episode, they're found by EMS. EMS knows exactly what their medical condition is. And then again, we may need to increase the hydrocortisone in times of stress. There are injectable forms of hydrocortisone for emergencies. So just like an EpiPen, they can carry a hydrocortisone pen with them. Adrenal crisis is going to usually, in the ED, be addressed via IV hormones and fluid replacement to correct the volume depletion. So that's level 3 therapies. That's going to be probably the mainstay for the more serious forms of adrenal cortical insufficiency. Level 4 is not really indicated unless there's an adrenal tumor or something like that. Pituitary tumor would need to be addressed there. Level 2 therapies, actually let's go back to level 1. No guidelines here, but makes sense that healthy diet, exercise, lifestyle, stress reduction would all be important there. These will be very important for the more functional adrenal problems. Supporting salutogenesis, again, may have a secondary role for true adrenal cortical insufficiency, but here this is going to be more applicable to the functional adrenal disorders. But we might think about things like the stimulant adaptogenic herbs, ginseng, all the ginsengs, rhodiola, Codonopsis, Pseudostellaria, Schizandra, astragalus, Aralias in the ginseng family, and then licorice. This is, of course, very different, as I explained earlier, between the so-called sedative adaptogens like ashwagandha, bacopa, and holy basil, which tend to decrease the HPA axis. These are all trying to increase the activity of the HPA axis, and if there's any adrenal function, that should help with that. So many of these herbs can potentially be helpful in the autoimmune process as well. Different nutrients that are needed for adrenal steroid synthesis: vitamin C, B5, D, selenium, iron, and copper. So that is an overview of the therapeutic order for adrenal cortical insufficiency. For the biomedical conditions, really we're going to focus on level 3 therapy, usually going to need a referral to an endocrinologist, potentially the ED if there's an adrenal crisis. The good thing about this is that these are very true cases, are very rare, but it's important to know how to recognize them. Okay, so that wraps it up for adrenal cortical insufficiency. In the next video, we'll look at adrenal cortical excess.